All right, I'd like to thank the organizers and sages for the privilege of the podium today, and it looks like I have the easier job, so I appreciate that. I'll just take the moral high ground. These are my disclosures, none of which are pertinent to today. So really, why shouldn't you repair this hernia first, right? Well, let's start by saying we all wanted to be good doctors, right? Hippocrates told us how to, William Osler told us how to, and really, it's about good health, and we should ask ourselves, are we ready to do away with the reasons for the illness and not just the problem? And William Osler said the same thing. The good physician treats the disease. The great physician treats the patient who has the disease. And clearly, in this case, the patient has a significant disease that impairs their lifestyle long past their umbilical hernia, and to a significant degree more so than her umbilical hernia. So I think, really, if I have to climb on a soapbox, my thought is to be a good physician first and a surgeon second by treating the disease and not just her problem. That way, instead of a quick fix, you're trying to positively impact her quality and quantity of life. So that takes time, that takes effort, it certainly takes counseling, and so all of these things are oftentimes difficult for patients who walk in with a plan for a hernia repair and leave with a discussion about bariatric surgery, for instance. So why would I do that first? Or if the patient wants it, why would we go the weight loss route first? Well, for all the reasons that you're well aware of, right? Certainly we can alleviate her reflux. I don't know any orthopods that will operate on a BMI of 58 for a knee, but if these ones will, we can certainly improve her outcomes after total knee arthroplasty revision, which is prevalent in the orthopedic literature. This operation may not be available to her in the country she's going to, and so if she's here for a prolonged period of time, that's something she could consider. And of course, it's going to lower the risk of hernia recurrence and reoperation. It would be ideal to get this patient 2 operations, right? Because if we do the hernia first, she's probably going to end up with 3 operations. She's not going to get her reflux fixed, she's not going to get her sleep apnea fixed, and she's at increased risk for hernia recurrence, and I'll show you that in the data in just a second. So while it's great to generate work RVUs to subject the patient to 3 operations, if there's a way to avoid that and improve her quality and quantity of life, why wouldn't we? So in a large French database study where they looked at ventral hernia repair and obesity, they took a large portion of patients, and you can see the numbers of each group there. One group was a ventral hernia repair 2 years before a metabolic or bariatric procedure. One had their repair done at the same time, and one group had their repair done 2 years after a metabolic or bariatric procedure. And what they found was, not surprisingly, in this large database study, was that those patients in the group who had their hernia repair fixed prior to weight loss all had a statistically significant higher rate of hernia recurrence. And interestingly enough, those who had their primary hernia repairs fixed at the same time as their weight loss operation had the lowest risk of recurrence. So some more data. What about predictors of ventral hernia recurrence, and how does it pertain to this patient? Well, this was a recent systematic review and meta-analysis of over 274 qualifying papers. And not surprisingly, and I think we all know this, the significant patient factors that are related to her hernia recurrence, she has all of them. She identifies as female, she has a BMI greater than 40, and she's certainly a high ASA grade because of her BMI and other comorbidities. So we'd have to counsel her about the fact that her hernia recurrence rate is significantly higher, and we know it. And so does Dr. Dierenberg, because she and others helped write the EHA's guidelines that are utilized in helping us to decide this exact question. And while the data are somewhat weak, and these guidelines came out before those 2 papers that I just showed you, even the EHS suggests that weight loss to a BMI below 35 prior to elective or umbilical hernia repair is advisable. So before you vote, remember that my colleague is very smart and knows how to achieve good hernia outcomes and does so every day because she mitigates risk factors just like these and has the patient at heart and their best interest at heart. And I think so should we when we consider this case where weight loss prior to hernia repair is the best approach. Thank you.